Good afternoon, everyone, and certainly welcome to our annual Siciliano lecture. We actually come together this afternoon to learn and to celebrate the life of John Siciliano. So Mr. Siciliano was a patient of mine, and he and his family and I became very close once upon a time. John eventually succumbed to metastatic adenoid cystic carcinoma, a very tragic and sad, but the Siciliano family has remained very loyal to our cause of medical education and research. And so they live in neighboring Steubenville, Ohio, which is a little over an hour from Pittsburgh. Although in the last few years, Huberta Siciliano has been living largely in Chicago, where she's closer to her grandchildren. And I think Huberta is going to join us this afternoon. Are you on, Huberta? Maybe not yet.
I'm not seeing her popping in yet, but she could be on one of these other phone numbers.
Yeah. So I'm delighted to have the opportunity to introduce to you our Siciliano lecturer for 2021. Dr. Cherie-Ann Nathan is the Jack Poe Endowed Professor and Chairman of LSU, Shreveport Department of Otolaryngology, where she's also Director of the Head and Neck Oncology Surgery and Research at the Feist-Weiller Cancer Center. Cherie-Ann did a residency after doing medical school in India. Cherie-Ann did a residency at UC San Diego. She's then did a fellowship at Johns Hopkins. She is a surgeon scientist who has over 20 years of continuous NIH funding. Cherie-Ann is the recent past president of the American Head and Neck Society. She's on the board of the American Board of Otolaryngology, and she's a president-elect of the Academic Association of Departments of Otolaryngology, which is the Chairman's Club. She, in 2019, was elected to the Shreveport Business Hall of Fame. It's amazing. So Cherie-Ann and her husband, a physician, have 2 boys. And here's a few things you don't know. Cherie-Ann is a classical pianist. She, at one time, was a ballerina and dancer. And at the same time, she was a sprinter on the track team. So she's very athletic. So Cherie-Ann, we're delighted to have you with us virtually, I understand, but we're delighted to have you here serving as our annual Siciliano lecturer. And perhaps we'll have you go ahead and share your screen and talk to us about bench to bedside and back in the management of high-risk kidney cancer.
Thank you, Dr. Johnson, for the kind introduction. I'm really honored to have been invited to give the Siciliano lectureship, not only because of what it looks like the family embodies, but because I have really admired your department as it continues to produce great leaders. Dr. Johnson, I'm humbled to be invited by you right before you retire. Dr. Myers, I'm not sure if you're on Zoom, but I continue to be your admirer as you've shown all of us how to build a great department, but more importantly, how to also balance professional and personal life even now. Dr. Ferris, of course, a dear friend who has been at the cutting edge of everything new in otolaryngology, offers and amazes us with his ability to multitask. And really so many others in your department, Dr. Johnson, Dr. Duvery, Dr. Snyderman, and others too numerous to name, all who have propelled our field through their inquisitiveness, intellect, drive, and vision. So like Dr. Johnson said, although I was hoping for an in-person get-together to meet you all, mingle, network face-to-face, a big part of what is so important in academics and I think in life, I'm glad that there's hope for normalcy in the future. So I'm going to share my screen now, and are you all seeing it?
Not yet, Dr. Nathan.
Not yet.
No.
There we go.
Here it comes, I think.
Okay,
Perfect.
and I have to change one more setting, I think.
Yeah, the display setting.
Okay, does that work now?
Yes.
All right. So when I was asked to give this lecture, I decided I'm going to talk about my path as a surgeon scientist, as I'm presuming there are residents and fellows on the call today, embarking on their career, and know that the end game is never give up if you have a passion. So I titled my talk From Bench to Bedside and Back in the Management of the High-Risk Head and Neck Squamous Cell Cancer Patients. So, we've all seen this increase in HPV-associated cancers, and now so we have these two different diseases, the HPV positive that do so well, and then we have the HPV negative who don't have a much lower survival. And you see this, the hazard ratio of death, both shown very nicely by Dr. Fakhri and Dr. Cherie-Ann in their studies. And then in the RTOG trial, they further divided these HPV cancers into low risk, intermediate, and high risk based on your smoking history, and then some other criteria of N status and T status. But you can see here the low risk patients, 88% at 5 years, and that's the HPV positive non-smokers. And then you have the high risk HPV negative smokers, and then your intermediate risk. So we clearly still have a big problem with the high risk for sure, and even the intermediate risk. And in this study here, retrospective review of 514 patients in Brazil, USA, and Europe, what you see is that low risk group, great survival probability, and then you have the intermediate risk group. The question I think people ask is de-escalate, but then there's this group of patients, and that's the group I'm going to address today, HPV negative patients that are the smokers, because throughout the world where head and neck cancer is very prevalent, it's still largely a smoking disease related tumor. And I would not talk about HPV positive with the gurus being in your department, Dr. Ferris, Dr. Duveri, all at the cutting edge of treatment for this disease. So when you look at what TCGA study showed, when you have the HPV negative and the HPV positive patients here, and you see largely big difference in the profile of these patients, with the HPV negative patients having P53 mutated patients. Greater than 80% of patients have P53 mutations, as well as CDKN2A. So I think the problem, that brought me from India to the US was I was frustrated with the recurrence rate of our head and neck cancer patients, and thought maybe we weren't practicing state-of-the-art disease. And so came on a scholarship to Johns Hopkins to do some research, and realized that the recurrence rates was just as high here, and it's the nature of the disease. And unless we do something to change those outcomes with our research, we're probably not going to make much of an impact. And that's what really got me excited about research. And in this paper here by Dr. Davidson, who was at UCSD where I trained, he actually looked at surgical margins that were deemed microscopically negative, but they did Mohs margins on all these upper aerodigestive tract tumors, and showed 50% of tumors, patients actually had positive margins in what was thought to be microscopically negative. So there's clearly a need for adjuvant or chemopreventive agents. And I think we've all struggled with what are the molecular biomarkers that could identify patients at high risk for recurrence and determine response to treatment. Are these cells we're leaving behind in our surgical margins pre-malignant cells destined to tumor progression? How do we address this problem? And here's an example, a patient that had a tongue cancer, beautiful outcome, good reconstruction, good speech, swallowing, and in less than 2 years, patient recurs right at that site. So I think clearly there's a need for adjuvant therapy. When you look at the factors influencing survival, it's positive or very close margins, extranodal extension, nodal mets, perineural infiltration, and lymphovascular invasion. And in, I think, 2004, these studies were published. 2 groups, EORTC and the RTOG group, looked at the addition of adding cisplatin to radiation compared to radiation alone as adjuvant therapy, and found there was a 10 to 13% absolute benefit in local regional, no difference in distant mets, but the doubling of toxicity with that treatment increased from 34% to 77%. So clearly, although this adjuvant therapy with cisplatin and radiation worked better, significant increase. And so there's a need for alternative therapy. Now, Vogelstein has shown that tumors progress via sequential activation of oncogenes and then deletion of tumor suppressor genes. It's like the accelerator. Once the accelerator and the tumor suppressor gene is the brakes of the car. And that normally, this imbalance gives the cell subpopulation growth a survival advantage. And this paper here, published by Arlene Forestier's group in New England, shows how with increasing grades of dysplasia, normal mucosa to hyperplasia, dysplasia, carcinoma, and carcinoma, in situ and carcinoma, you can see along each step of the way, there's genetic changes that occur. So what if we can inactivate one of these changes that in this genetic profile of these minimal residual disease cells that we're leaving behind? Can we ultimately help our patients and change the outcomes? So when I came to LSU in 1996, I think Wayne Koch's group had just looked at P53 in surgical margins. It was the very first study before they continued with the ECOG study 4393, I think, and showed with POERA the long-term survival. But at that point, all they did was look at the margins and find that a significant number of the patients had P53 mutations in the margins, and some of these patients recurred. So, I was looking for who do I collaborate with. I came to LSU just for a year to get my green card. So I hadn't negotiated for lab space, so was planning on going back to San Diego. So I talked to one of the biochemists and said, what are you working on? And he had just published this paper on a proto-oncogene EIF4E, which he had overexpressed in HeLa cells and found that they caused malignant transformation. He was just looking at it to study protein translation and was surprised that it caused malignant transformation. So what is EIF4E? It's a translational factor that is present in every cell under normal quantities. So when it's present in normal amounts, the strong messages with the housekeeping genes get translated. However, when 4E is overexpressed, then the weak messages start to get translated because the strong messages are already maxed out. And when you look at what is this list of weak messages that get translated in the presence of excess 4E, it's proto-oncogenes like c-MYC, growth factors, VEGF and FGF2, both very important angiogenic factors. So I said, let me look at EIF4E, never heard of it, and asked him if I could send him my patient's tumors and surgical margins because I wanted to see was 4E expressed in the surgical margins. So my very first patient was a case at the VA, T4 laryngeal cancer. And we did a total laryngectomy, bilateral necks. Surgical margins were all histologically negative. And interestingly, when I gave Dr. De Benedetti's lab the tumor and all the margins, the inferior tracheal margin was positive. And this is the very first Western his lab ran for me. N27 is a Zenker's diverticulum, which I used as a normal control. Here's the tumor T4. And this was that inferior tracheal margin SM4. And you see overexpression of 4E. So it's like, are you sure you didn't mix up the samples? And, they said no. They ran this a couple of times and the margin overexpressed. And in about 2 or 3 months, this patient developed this stomal recurrence. And that was like the very first case I looked at. And I was like, wow, this is so interesting. So I asked Dr. De Benedetti if he would continue to collaborate with me and test my patient's samples in the lab. And so this is one of the initial blots. Here's the tumor. The tumors all have alternating bands overexpressing 4E. And then this is one of, the normal margins. So in this upper blot, none of the margins here I'm showing you overexpress 4E. N27, that's Zenker's. I used them for a mucosa from that patient for a long time. This was in the days before endoscopic, the open approach. And so I had some mucosa. And then here's another blot of some other patients. And you can see patient 11, T11 is the tumor, and it was a piriform sinus mucosa, piriform sinus tumor. So I had 4 margins. 2 margins overexpressed 4E and 2 didn't. So what was interesting is it's not a field effect. It wasn't like all the margins, only some margins overexpressed 4E. And this patient recurred as well. And so was patient 8. Here you can see 1 margin, 2 margins are negative and 1 margin was positive. So we then, said, this is interesting. We're seeing recurrence in some of these patients. So I then performed a retrospective study and looked at patients who were disease-free for years or had succumbed to disease. And this time we did immunohistochemistry staining by getting their blocks from pathology. And what we found was when 4E was overexpressed in the basal cell layer, those patients were recurring. And that was only when it was overexpressed in the basal cell. So in 1999 then, we completed a prospective trial on analysis of surgical margins with 4E. And that was the time we got our first R21 to do this trial. And all patients that underwent surgical resection and their margins were negative, the pathologist stained it for 4E and gave me the results. And then we followed these patients out for 2 years. And what we found in that study was patients with 4E positive margins were recurring much more frequently than the 4E negative margins, p-value of 0.03. And if you look at these recurrences, most of them are happening in the first 2 to 3 years, which is when most of our local regional recurrences occur. So what does a 4E stain look like? This is a squamous cell of the tongue, I think. And it's a reddish brown perinuclear stain. And these are tumor cells. Now, this is a margin from one of the patients in the study. And you can see here, this margin did have high-grade dysplasia, but when stained for 4E, there's no staining of the basal cell, or really in this slide, not much staining at all. And this patient, at least when I published this study, or later on, was disease-free for a number of years. This is another patient, and again, high-grade margin, high-grade dysplasia, because often the entire field has field cancerization. So sometimes you do close on various grades of dysplasia. And here you can see the basal cell layer stained positive for 4E, and this patient recurred in less than 6 months. So we had a potential marker that could predict recurrence from this prospective study. So the question is, what can we do for these patients with molecular positive margins or minimal residual disease identified by EIF-4E antibody? Further excision would have been the best if we could stain this during frozen sections, which can't happen. It's too long a process. Now, this studies were done in 1997. In those days, post-op radiation therapy alone was standard of care for adjuvant therapy, not cisplatin and radiation. So at least in these patients with 4E positive margins, radiation alone was not sufficient and they were recurring. So went back to Dr. De Benedetti. By then, I had applied for an academy grant, I think the Earl Elkins, and got some funding. And then our cancer center director was really helpful in, supporting a technician to help me with getting some of the preliminary data. And so, Dr. De Benedetti and myself continued to collaborate. And I said, what do we do for these patients? And right about that time, in 1997, 1998, rapamycin, of course, had gained popularity as an immunosuppressant in renal transplant patients. And the NCI found, interestingly, it also had anti-tumor effects. So he asked me if I, thought about using that. So why rapamycin? So when AKT is activated, it phosphorylates phospho-mTOR, that then phosphorylates this binding protein of FOE. So FOE stays bound to the binding protein. And when it's phosphorylated, it releases this FOE to say, hey, let's cause translation of all these weak messages you see here, VEGF, FGF, and cause tumor progression. So we thought, what if we use rapamycin or these analogs? Wyeth was making CCI779, which is temsirolimus, or Novartis had RAD001 everolimus. What if we use this drug to inhibit the mTOR, inhibit the phosphorylation, and so prevent the release of FOE in these minimal residual disease cells? Maybe we can help these patients. So now I went back to our entire tumor bank of patients that we had, their margins, both on immunohistochemistry and Western blot, because the next question was, we know EIF-FOE is overexpressed in these margins, but what about phospho-mTOR and phospho-FOE-BP? Is FOE really functionally active in these surgical margins through the mTOR pathway? And maybe then we can use the mTOR inhibitors in these patients. And this was published in a clinical cancer research in 2004. And we found basically that there was a strong correlation. So here's FOE in a tumor, phospho-mTOR and phospho-FOE-BP. And then you have the FOE negative margin. Now, again, remember we mentioned basal cell layer had to be positive for these patients to recur. So even though you have some suprabasal staining, I don't know if it comes clearly, but it's blue in the basal cell layer, both for phospho-FOE-BP, FOE, and then phospho-mTOR. And in the positive margin patient, it was positive for all. So there was definitely, it was functionally active through these margins. Now, this was interesting. We also went back to our bank and did Western blots. And here's FOE tumor. Here's a margin that's negative, tumor, and a margin that's negative. But then these are two other patients, tumor, and this margin is positive, and this margin is positive. So when you look at FOE-BP, it's negative. But because I was comparing tumor to margins, I was really surprised to see this. So the tumor had the lower bands overexpressed. And these are the unphosphorylated bands, which means FOE-BP is not functionally active. So it was really in these margins, the advancing edge of the tumor with these minimal residual disease cells, that mTOR appeared to be activated in the FOE positive margins. Now, that was the time Charles Sawyer had started working on mTOR inhibitors for, I think, prostate and breast cancer. But prostate and breast, first of all, for mTOR inhibitors are cytostatic. They're really not cytotoxic. So using it as a cytostatic agent alone would not work, but could work potentially in minimal residual disease if you're preventing the patients from recurring. So we went to Wyeth, presented our data to Wyeth, and showed them our results and asked if they would be willing to send us temsirolimus, CCI779, because we thought we potentially had a minimal residual disease model that their drug may work. So they gave us the drug, and this is just an early experiment in nude mice where you see your control, and then we tested the different doses of the drug, and we found we were able to inhibit growth of the tumor, and you can see here the tumor volume significantly decreased, even with a low dose of the drug. And when we did our survival comparisons in these nude mice, there was an improvement in survival that was significantly different. So from these mice, we also obtained PBMCs. And the reason I wanted to look at PBMCs was if we were going to use this drug as adjuvant therapy, there was going to be no tumors to look at pathway effects. And so I wanted to be able to have a surrogate marker. And so wanted to see if we could use PBMCs as a surrogate marker. And you can see here, no drug, but after 5, 10, 15, and 20 mg per kg of the drug, the bands move to the lower bands, indicating that 4-EBP is being unphosphorylated or inhibited. So we had a good potential PBMC as a surrogate marker. Now, a few years later, it was nice to see, whenever you do something that is you're excited about, it's always great when other groups are able to replicate some of this information. So this study was looked at rapamycin in genetically defined epithelial cancer models, 2-hit animal model on oral squamous cell for KRAS overexpression and P53. And you see your vehicle and rapamycin, and you see the rapamycin mice have no tumors compared to these large tumors in the control. And you can see that here. And they also show that the pathway was inhibited. Phospho-S6 is a really good readout for inhibition of phospho-mTOR. And you can see on the rapamycin group, the pathway was, phospho-S6 was inhibited. And you can see that on the Western as well. And then I think many of you know Dr. Silvio Gutkind, and he published this in Cancer Research in 2009 too. He looked at 4-NQO, which is a chemical carcinogenesis model. He gave mice, their drinking water, 4-NQO, and that normally forms tumors. And you can see all these tumors in the control group, but in the rapamycin group, the 4-NQO was inhibited tumor formation. And again, you can see squamous cells per tongue, and this is rapamycin significantly decreased, as well as the pathway is decreased. So, went back to Wyatt because we wanted to now do a clinical trial, and said, they wanted to know why head and neck, it's an orphan disease. There's a lot more, money to make in breast and lung and prostate. And so we said, recurrence occurs in less than 2 years. Easy accessibility to tumor biopsies without having to undergo endoscopy, like is in lung and colon. And then NIDCR had shown that majority of head and neck tumors have PIK3 abnormalities and activation of the AKT-mTOR pathway. So they agreed for us to do the first pharmacodynamic phase 0 trial with temsirolimus, which was CCI 779. And, the primary objective was really to see if our patients tolerated it and if we could inhibit the pathway in these patients. So what we did was patients that were newly diagnosed, even if they were going to go on to have chemoradiation or surgery, 3 weeks prior to beginning their treatment, they were given IV temsirolimus 25 milligrams once a week. And then at the end of those weeks, we rebiopsied the tumor 24 to 48 hours after the 3rd dose of the drug. Now, I also took video pictures of some of the patients just to see, what happens with mucositis and some of the side effects. But the real goal was to assess target expression as well as see if these patients tolerated it. Because I think a big question was, you're using an immunosuppressant. Head and neck cancer patients are already immunosuppressed. Is you sure this drug is something they're going to tolerate? So here's results of that. And you can see phospho-S6. This is pre-treatment. This is post-treatment. And phospho-S6 decreases phospho-4-EBP. This is FGF, all decreasing pre and post 3 weeks of the drug. What was interesting, in about 60% of our patients, there was actually tumor shrinkage, which I wasn't expecting because it's thought to be more of a cytostatic drug. And in 3 weeks, I really wasn't expecting. But a couple of patients had trismus and their trismus disappeared. And so there was some effect even in tumor size. And so I then went back and looked at PARP, which is a marker of apoptosis. And in so many of these patients, PARP was increased, indicating there may have been some apoptosis even within 3 weeks. Side effects were minimal: skin rash, hyperlipidemia, fever, thrombocytopenia. Now, we did that in 2010. But again, always nice to see somebody else reporting similar results. So 2019, Terry Day, along with Silvio Gutkin, Carter Van Voice, published their work. They used rapamycin, exact same trial window of opportunity. They gave rapamycin for 3 weeks and then biopsied patients. The difference was they also had PET scans in their trial after 3 weeks of rapamycin. And you can see most patients actually had some tumor response based on PET. This one patient that you see here actually landed up with 3 weeks of rapamycin having a complete response. So, adjuvant therapy, right, for our high-risk patients. Cisplatin became standard of care with radiation in 2004. Now, we all know about cetuximab. Cetuximab, unfortunately, the trial proposed started way back before cisplatin became standard of care. And so people compared it just to radiation alone and radiation and cetuximab. And what we found was, yes, cetuximab and radiation worked, and you see that's the blue line, worked significantly better than radiotherapy alone. But like I said, that was way before cisplatin became standard of care. We now know, though, that when compared to cisplatin and radiation, that is not the case. Here's our local regional recurrence with cetuximab significantly higher compared to cisplatin. And here's your disease-free survival. This is with cisplatin and cetuximab much worse. So clearly, cetuximab is not the answer. Cisplatin is still the standard of care, but patients are still recurring with cisplatin and radiation, and cisplatin is toxic. So there's a need for alternative targeted agents. Now, what I realized was radiation actually activates the PIK3-mTOR pathway. And when it phosphorylates phospho-S6, it phosphorylates bad, causing cell survival. So we thought, what if we inhibit it with mTOR inhibitors, inhibit phospho-S6, and then that would cause cell death through apoptosis, caspase, and PARP. Maybe that would work. So I'm just going to show you in vivo data in our mice where we compared cisplatin alone, but really the goal was cisplatin and radiation that you see here to radiation alone. We know cisplatin and radiation will do better. What was surprising is CCI and radiation, the mTOR inhibitor and radiation did really well. And adding it to cisplatin, there was really not beneficial. Now, mind you, this is in mice. It is always going to be hard to compare something that's standard of care and get away from cisplatin. You've always got to add another drug. We harvested these tumors from these mice here to see how was this drug working along with radiation, and why did we see such a great inhibition in tumor volume? And we stained these tumors with CD31. Now, when I did these experiments on cell lines, there were no radiosensitizing effects on colony assays. However, it worked beautifully in vivo. And so we realized it was an effect on the tumor microenvironment and not necessarily just the tumor cell growth. So you can see your CD31 stains the blood vessels. And when you look at CCI and radiation and the average number of blood vessels, there appears to be a decrease in the blood vessels, indicating anti-angiogenic effects of mTOR inhibitors. We also saw apoptosis along with radiation. So you see your CCI and radiation, a significant increase in apoptotic by using the tunnel assay in apoptotic nuclei. Once again, many years later, we saw this publication out of Sloan Kettering group by Mark Fury, where this group conducted a phase 1 study of everolimus. Now, everolimus is also an mTOR inhibitor, but it's the oral formulation, which is way better because patients are not going to come back for adjuvant therapy every few weeks to get their IV dosing. So it's a lot better to use everolimus. So he compared everolimus with weekly cisplatin and IMRT to see if patients tolerated it, with the hope of maybe going ahead with a trial combining these three drugs to improve recurrence. And what he found was they tolerated it well at 5 mg per day, given with weekly cisplatin and IMRT. But what was very exciting in their publication is they felt it may work for 4E positive patients. The patients who experienced disease recurrence actually had elevated 4E expression in histologically tumor-free margins. So it was nice to see somebody else had noted that. And finally, talking related to this before I go on to the clinical trial we just completed, lymphatic spread. We know the head and neck has rich lymphatic work, and tumor cell dissemination is the first step in METs, and patients have poor prognosis. So we also know extranodal extension is a poor prognostic factor. Now, not for the HPV positive, but definitely for the HPV negative. So we obtained some cells from Eben Rosenthal, OSC19 cells that you can actually implant into the tongues of mice. And then it actually metastasizes to lymph nodes in the neck, and you can identify these lymph nodes by methylene blue. We harvested the tumor, and you can see our control and then our rapamycin treated group. And we stained the lymphatic vessels in the tumor with Lye-1. And you see a significant decrease in the number of lymphatic vessels with rapamycin, indicating it also plays a role, not just in angiogenesis, but maybe lymphangiogenesis. Now, one of the things our pathologist kept reporting when she was reading these mice slides was metastatic lymph nodes with subcapsular tumor localization. And what I realized was rapamycin, so here's rapamycin. If metastatic lymph nodes was extensive in the entire lymph node, you can see that was the case in 79 or 80% of our control, but only 26% of rapamycin. But when rapamycin mice did have some metastatic nodes, it was never filling up the whole node like this. It was either negative in the node or just subcapsular localization. It did not have extranodal extension, which was a little surprising. So again, in 2011, this group also looked at inhibition of mTOR and found that it actually diminished the growth of these tumors and prevented metastatic spread to lymph nodes. So here's their vehicle. They looked at RAD001 and rapamycin. Rapamycin has been around so long for renal transplant, and it's very cheap compared to all these other agents. And so I'm glad they tested it, and you can see here a significant decrease in nodal mets as well. So it appears 4E overexpression in margins predicts recurrence. mTOR activation in these margins indicates that these patients may benefit from mTOR inhibitors. It could be a potential radiosensitizer. And mTOR inhibitors may be working through antivascular effects. So what's next? We now needed to design the clinical trial as head and neck surgeons with targeted therapy. So I think we all quote Drew Ridge from his talk during his presidential year. We show pictures, they show curves. And I think the surgeons did take this seriously. You see here in this decade, the number of clinical trials that occurred, and none of them were by surgeons. And then the following decade, the number of trials, and 4 of the trials were by surgeons. And none other than many of these trials are Dr. Ferris, who's led some of these trials, including nivolumab for recurrent squamous cell cancer. So we decided, let's do the multi-institution randomized double-blinded phase 2 trial, comparing everolimus to placebo as adjuvant therapy in these patients with advanced, locally advanced head and neck patients. And this trial was done with University of Chicago with Ezra Cohen, who then landed up leaving and going to San Diego, and Everett Vokes took over as study co-chair. And patients, the eligibility criteria is they had to be stage 4A or B, and baseline functional quality of life assessment. they either had to be HPV negative, or if they were HPV positive, they had to have greater than 10 pack years smoking. And then they were stratified based on the treatment, whether they got chemoradiation or surgery followed by chemoradiation, and they were stratified by treating institution. Now, what I've realized, it is so hard to do clinical trials. It takes forever, like you've seen with many of these trials close. So although the accrual goal was 160, we finally did have to close the trial because it was hard to enroll patients. I think head and neck cancer patients are so burnt out after their treatment that to go on one more year of adjuvant therapy with the hope that you're going to improve their survival, I think sometimes is difficult. The endpoint for that trial was follow-up 2-year progression-free survival, local regional recurrence, but we also wanted to look at molecular predictors of response. These were all the institutions that participated in this trial. And you can see here, the patients were equally balanced in placebo and everolimus, whether based on site, stage. It's interesting, T4A or B, there were actually many more patients with higher T4 stage in the everolimus group. And by intervention to placebo and everolimus, whether they got radiation, radiotherapy, equally balanced, again, that was obviously expected. So the adverse events were really minimal. We had less than 10% of patients have grade 1 and 2, and one patient had a grade 3. And then we did have a thromboembolic event. It wasn't really as a result of the drug, but one would never know, and a skin infection. So what did we find in this trial? So I'm first going to talk about the primary endpoint, progression-free survival. It did not reach significance, 0.05, but we only had 52 patients instead of 160. We had to stop the trial. However, if you look at patients who were on placebo, the red line, they were recurring much more frequently. And they got drug for the first 12 months. So while patients were on the drug, you can see the blue line, which is everolimus patients, the recurrence was just not as frequent. And here they got taken off the drug. Overall survival was no different. We then sent all the tumors at the start of the treatment. This was prior to getting their definitive treatment, to Dr. Neil Hayes at UNC for target exon sequencing. And then his results were sent to UCSD, to Dr. Gutkind and Harris Mandy for the bioinformatics. And this is the exciting result. So when you looked at progression-free survival, 2-year progression-free survival, on just P16 negative patients, there was a significant improvement in these patients' progression-free survival compared to placebo. That was not the case for P16 positive, for P16 negative. We also, as we know, P16 negative patients have significant number of patients have P53 mutations. In the wild type group, there was no difference between placebo and everolimus. But in the mutant patients, again, our p-value was 0.027. And you can see here, placebo recurring, but the mutant patients, there was a significant improvement in progression-free survival. Now, this was a subset analysis. The study was not powered to look at this, but it's still exciting that there is a potential for P53 mutated patients. So here's our patients, as was expected. Most of our HPV negative patients had P53 mutations. So is it an effect of being P16 negative or P53 mutations? It's probably mutations, but that's what we're trying to understand. So the question was it equally balanced between placebo and everolimus in the number of patients that were mutated and wild type, as that was just a subset analysis and they were equally balanced? Also, in terms of treatment between the wild type and mutant, they were equally balanced in type of treatment, and yet we saw an effect. I think I'm going to go back here, but I think one of the problems is when patients do so well in the wild type, you're not really going to see an effect of the drug. And same here, P16 positive patients do so well. It's very hard to see whether adjuvant therapy is going to help. But clearly, the P16 negative and P53 mutated patients benefit. So, our sample size was small, but I think it's exciting that HPV negative patients with P53 mutations appeared to benefit from everolimus. Everolimus was well tolerated. So I think targeted therapies as adjuvant therapy has provided disease control in multiple tumors, breast and renal cell carcinoma. Patients have been on everolimus for years. I think in renal cell, they've tolerated it for 4 years. So the plan is to conduct another prospective trial on just P53 mutated patients. So this is where I say from bench to bedside. And now we're back to the bench, right? Because the question is, this was a surprise. Why did patients with P53 mutations benefit from mTOR inhibitors? The effect, we know P53 mutations is associated with radioresistance and have poor prognosis, likely varies with the type of mutations and coexisting. Now in this trial, I think Dr. Ferris was involved, ECOG 4393. POETA showed that when you had disruptive mutations, those patients did the worst compared to non-disruptive, and then of course wild type did better. And then I don't know if Dr. Myers is on the call, but Jeff Myers is looking at a novel way, this evolutionary action, where they're able to classify P53 mutations into these low risk and high risk mutations. And here he shows patients with high risk mutations do significantly worse than low risk mutations, as well as with time to distant metastasis. And in fact, he's also shown that it predicts response to platinum-based chemotherapy in patients with locally advanced oral cavity. So P53 mutations, we don't know, which mutations could benefit, but we went back to the drawing board to find out why rapalogs would work with these P53 mutant. And this is what we could come up with. Mutations in P53 actually activates the mTOR pathway, can phosphorylate STAT, activating HIF1 that translocates to the nucleus and then causes transcription of VEGF mRNA and then increases VEGF, maybe angiogenesis and tumorigenesis. So we've got these minimally residual disease cells after our definitive treatment. Maybe we're preventing them from growing through angiogenesis and keeping them static and increasing survival. So we got the cell line HN30 and HN31, wild type P53 and mutant P53, I think from Dr. Opalvari, and looked at the effects of everolimus. And you can see here the control and tumor. This is the mutated. Then we looked at the wild type. And disappointingly, it wasn't an effect of P53. The wild type actually responded equally well with the everolimus, including survival. When we looked at the pathway effects to see what happened to HIF1, we were surprised. HIF1 alpha was completely down, as was VEGF-A. So it may be working through this pathway, but again, it wasn't an effect of P53 itself because the wild type worked as well. So we then did some experiments on 2 different cell lines, FADU and HN31, since VEGF was down, to see what does it do to angiogenesis or microvessel density. And this is HN31 control stained with CD31. And you can see when treated with the drug, significant difference in angiogenesis. This is a minimal residual disease model. And this is the other cell line, FADU. So it is inhibiting angiogenesis in both these P53 mutated cell lines. So your question is going to be, well, if it's not mTOR, it's not P53 mutation patients that are benefiting as equally beneficial to P53 wild type, then why won't any drug work, right? But we know they've tried afatinib, it hasn't worked as adjuvant therapy, but we decided to go look at cetuximab in the lab. And what we found is in nude mice, when they were treated with cetuximab, after 49 days, they developed resistance and the tumors grew. But with everolimus, we didn't see that resistance. And there's other studies, I think, showing that cetuximab, that P53 may actually cause resistance down the road, especially in P53 mutation patients. So one other, this is the last part we're looking at. And, we have these residual disease cells. Is it angiogenesis we're inhibited? Or are these cells actually dying? So we wanted to look at apoptosis in the P53 mutant HPV negative cell lines. So from Jeff Myers, we obtained the PCI 13 with multiple different mutations, both high risk and low risk mutations. And you see here a number of mutations displayed. And we treated them with the drug. And you can see here, Rapalogs inhibited the cell growth in all these P53 mutated cell lines. However, when we looked at apoptosis, this last bar here that shows an increase is doxorubicin, the positive control. But you can see here, the number of apoptotic cells was no different after being treated with the drug compared to the control. So it's not apoptosis. And we looked at cleaved caspase and PARP and found it was not apoptosis. So what could be happening? We wanted to look at autophagy. So here you have mutant P53. It activates mTOR. And when mTOR is activated, it actually phosphorylates the inhibitor of autophagy, ULK1. So mTOR, when activated, it inhibits autophagy. At the same time, through this pathway, AMPK, it phosphorylates and activates ULK1, which actually causes increase in autophagy. So we thought maybe if we're giving them the mTOR inhibitor, we can inhibit the phosphorylation, and maybe these minimal residual disease cells could undergo autophagy. So again, all these cell lines with various mutations were obtained. And I want to go back because one of the downstream markers of autophagy is you should see an increase in LC32 or decrease in phospho-6-2. And what you see here is your control and RAD001. You can see compared to the control, every alternating bar is up, indicating with the drug, there's increase in LC3B2. And if you look at P62, which should decrease, you can see here, it decreases every alternating bar compared to the control. So we saw an increase in autophagy markers. So to prove that it's really autophagy, we then wanted to look at whether it actually activated the initiating protein ULK1. And you can see here with the drug, every alternate band, we were able to actually activate ULK1, indicating it actually activates the initiating protein ULK1. So then to really prove autophagy is occurring as a result of this, we took two autophagy inhibitors, ULK101 and 3MA. This is an inhibitor which is later in autophagy, but these are the initiators of autophagy. And you can see both these, when you treated it with drug alone, we activated autophagy because you see an increase in phospho-ULK. But when we inhibited it with these two inhibitors, we were not able to see that increase. So we really knew RAD001 was probably playing a role in autophagy. And finally did it in our FADU xenografts and HN31 in nude mice. Here we can see the drug inhibited growth. And then we looked at LC3B, and you can see everolimus increased autophagy in these mice. This shows PARP was not, and cleaved caspase 3 was not increased, indicating even in mice, besides in vitro, it was not apoptosis, but autophagy. And then in these mice, we gave them an autophagy inhibitor, 3MA. So here's our control. Here's RAD001, it inhibits tumor growth. Here's 3MA, it doesn't do anything. That's the inhibitor of autophagy. And when you combine RAD001 and 3MA, it reverses what RAD001 did, indicating autophagy is a potential mechanism. And this has just been accepted to molecular carcinogenesis. It's in press right now. So I want to summarize finally, from bench to bedside, now back to the bench to understand why this is working. There's a need for adjuvant therapy. I think in our P53 mutant patients, mTOR inhibitors hold promise. The mechanism could be antivascular or activation of autophagy in these patients with minimal residual disease. Future plans are to conduct phase 2 trial, randomizing this time just HPV negative patients after definitive treatment to rapamycin and placebo for at least 2 years, maybe even longer if they tolerate it, and then look at its effects on various mutations of P53. And I think rapamycin has been safely used in renal and breast for prolonged time and should be considered in high-risk head and neck patients. So I want to end with acknowledging so many people who've contributed. This is our lab group. I'm going to call out one person in particular because you all may know her, Jan Marie, who I think was an observer in Pittsburgh and has helped a lot with the work on autophagy along with Dr. Alam and Rong and Tara, our pathologists, our biostatisticians. And I am going to end there and stop sharing my screen.
Dr. Nathan, that's a remarkable story of 2.5 decades of work. Amazing. It's really amazing. We're so honored that you have shared this presentation with us. Thank you all very much. Have a good evening, Dr. Nathan. We'll see you in the morning.
Thank you so much, Jonas. Bye.
Okay.
Thank
Bye-bye.
you. Bye-bye.